Hi everyone, welcome to researchmd.com. We got another great topic today. Our topic is we're going to teach you everything about primary sclerosing cholangitis. Okay, so let's start with the primary sclerosing cholangitis. If you look at the definition of primary, it's a chronic cholestatic disease. Okay, chronic cholestatic liver disease characterized by extrahepatic and intrahepatic stricture. Right? Remember, when we talk about primary biliary cirrhosis, what should come to our mind is that classic imaging picture of beading, right? So you have like stricture, fibrosis of the extrahepatic and intrahepatic. Intrahepatic. So let me ask you this: when we talk about primary biliary cirrhosis, right? What do we usually get confused with?
But it's
I mean, we talk about, we have to differentiate between primary biliary cirrhosis and primary sclerosing cholangitis, okay? Yes. So what is the characteristics of primary biliary cirrhosis?
Intrahepatic.
Okay, yeah, it's mainly like in the liver or interlobular and the subtle ducts, okay? When you talk about primary sclerosing cholangitis, it can come intrahepatic and extrahepatic also. Remember that. That's very important, okay? And then you got this, you can see this nice picture, the bead formation right there, classic finding. So let's look at the epidemiology. Now, more common in men, okay? So when you talk about, what about primary biliary cirrhosis?
more common in women.
More common. It's like, I think the ratio is like 10:1. So this is more in men, age like 30 to 40 years. Now, etiology, mainly there's genetic and the environmental link is associated with it, okay? So you have to know like association with inflammatory bowel disease, like very, very common. When you talk about ulcerative colitis, like 70 to 80% of the people have ulcerative colitis, even Crohn's disease like 70%. So combining together, I would say there's a link between inflammatory bowel disease. Got it? Okay, now, what are the clinical features? Sometimes it could be like asymptomatic, but the presentation, we have to know about fatigue, pruritus, and then we know right upper quadrant pain, and jaundice may be like a late sign also. Okay, remember those are the classic kind of clinical features you want to get. Now let's look at the pathophysiology. Okay, what is the pathophysiology? We got like two components, right? One is always genetic component. There's like two genes, which is HLA, B8 and DR3. And then you have immune-mediated actions also going on, okay? So next thing is like, you got all these T cells and natural killer cell get activated. And then you got profibrinogen cytokines, there's inflammation and fibrosis. What does it lead to? It leads to cholestasis, okay? Then the major problems comes in. So you got like, we got a picture of a cholangiocyte over here. And then what happens is like, I think we need to understand, there is always in the body, there's a balance between acid and alkali, okay? So here, like what happens is like, there's something called a glycosaminoglycolic acid, right? Usually the normal mechanism is like you have two receptors, TGR5 and FUT2 receptors. They stimulate the bicarbonate to protect, and they create this huge bicarbonate umbrella, so many bicarbonate protect, and they just kind of come in and then join this acid and then kind of neutralize it, okay? So remember that. So that is a normal mechanism. So what happens in the primary sclerosing cholangitis, the normal mechanism is damage, right? You got this main receptors, TGR5 and FUT2, that get damaged. So there's inadequate secretion of bicarbonate. That's what the problem. So the umbrella, the bicarbonate umbrella. So if you have to take anything out of this, I say like a bicarbonate umbrella is kind of damaged, okay? Then what's going to happen? Glycosaminoglycolic acid, boom, come into the cell, start causing all kind of problems, right? They're going to start with injury and then start the apoptosis process, and then there's macrophages, lymphocyte, and you get the fibrosis, the classic, that's another examination question. They put the histological picture and the onion skin appearance right here. That is the main classic finding in the histology, and then that can also read sclerosis and stricturing. That's the main thing, okay? In a nutshell, there is genetic, immune-mediated, T cell, natural killer cells. There is inflammation, cholestasis. When come to cholestasis, the role of glycosaminoglycolic acid, normal umbrella mechanism of bicarbonate protection is gone. Not enough bicarbonate is not going to be secreted. So acid come in, damage apoptosis. Okay, does everybody got that? Now, how do you, like, what investigations? Main thing, the number one you have to check, alkaline phosphatase elevators, right? So when you have an alkaline phosphatase elevated, what you have to do is, you have to fractionate it, right? When you do the fractionate, it's like you do the gamma glutamyl transferase and check it. So alkaline phosphatase, now somebody tell me where alkaline phosphatase come from, 3 places?
Bone,
Bone,
liver,
Placenta.
liver,
Placenta.
and the placenta. So bone, liver, and placenta. Those are the three. Places you can get the alkaline phosphatase. So the first thing you always do is, like, when you have to do is you fractionate it. When I see an alkaline phosphatase, I order a GGT. If the GGT is high, I know it's come from the liver, right? So in this patient, you got an elevated alkaline phosphatase, and then you can also P ANCA is elevated. Like 70% of the cases, there's like 70% P ANCA is elevated. And the imaging study you do, the diagnostic study you have to do in this patient is like cholangiography by MRCP, okay? They got highest sensitivity and specificity on that. And then how do you treat it? Treatment is mainly what? What is the main treatment? Liver transplant, okay? So what are the other, symptomatic treatment we can do? Let's say the patient with the pruritus, right? With the pruritus, what do we use? Cholestyramine, right?
Cholestyramine.
There's like a role for cholestyramine. Okay, and then there is a role for ERCP, but only for like symptom release. It doesn't actually kind of treat the disease, and it does not cure the disease. So remember that it's all both like symptomatic treatment. Okay, and then what are the complications? Main thing is, you have to remember, is the pre-malignant disease, okay? When you talk about primary sclerosing cholangitis, it's a pre-malignant disease. So what is the malignancy we need to worry about in this patient? That is cholangiocarcinoma. That is the one you just have to worry about, okay? Then you can also colon cancer, especially the people with inflammatory bowel disease. And then other complications are like, you're going to lose all this fat soluble vitamins deficiencies there, vitamin A, D, K, and then osteoporosis is going to be there. And then what are the screening thing you have to do? The main thing you have to do, these people with the primary sclerosis, they need abdominal ultrasound every 6 to 12 months. And what are you looking for? You're looking for gallbladder polyp, okay? If there's a gallbladder polyp, it's better to take it out, do a cholecystectomy. Otherwise, it can turn into malignancy. So it's very important you do abdominal ultrasound screening every 6 to 12 months. You also make sure, like, if they're colonoscopy, if they're kind of related, like if this is related, like inflammatory bowel disease. And then you got hepatitis A, B vaccine. We know like protective vaccination should be done. Now, it's also good to know what are the most important prognostic factors, okay? Let's say number one is in the alkaline phosphatase, return to normal within 1 to 2 years. The prognosis is very good. Always remember that. So it's important to check alkaline phosphatase on a periodic basis. Females is a good prognosis. If you're diagnosed in a younger age, it's also a good prognosis. And that is the most important thing we just need to remember, okay? So in a nutshell, make sure we know it's like what? Primary sclerosing cholangitis, intrahepatic and extrahepatic, both affected, right? More common in men. And then we know the role of this T cell, NK cell, they talk about the bicarbonate umbrella. Okay, that's what they get the damage. And then alkaline phosphatase, always do fractionated, and you check for P ANCA, like 70% of them can have like P ANCA, and the diagnostic imaging gold standard is MRCP with cholangiography. Treatment, only liver transplant, okay? Even with the liver transplant, there's some incidents like it could, like 25% have like recurrence of the disease. So, but again, if I had to pick one, liver transplant is the treatment. And then complications, I pick cholangiocarcinoma, okay? And then ultrasound of the abdomen every 6 to 12 months, looking for gallbladder polyp, okay? Thank you so much for watching our presentation. Please subscribe to our channel. If you have any comments, please put it under the comment section. Thank you again. Bye.